Hello and welcome to the epilepsy section, and we're going to be rather focusing on status epilepticus during this session. And we're very fortunate to have three speakers who've made some of these seminal discoveries and done some of the seminal research into the clinical, biological and translational aspects of status epilepticus that have really led to a revalidation or a reassessment of our understanding and treatment of status epilepticus. And then we'll have two data blitzes, which will be on slightly different topics, but obviously related to epilepsy. So without much more ado, I'd just like to first of all introduce our first speaker, who's Professor Eugen Trinka, who's from the Paracelsus Medical University, Salzburg, Austria, to talk us through really a teaching talk on where do we stand in status epilepticus.
Dear Matthew, many thanks for the kind introduction, dear colleagues, dear friends. So I'm talking about the current state. Where are we now in status epilepticus? These are my disclosures. There are four questions. What is status? What types of status do we know? And is it relevant at all? How do we currently approach status epilepticus, and are we missing something? The short answer is yes, we do, but I come to that point a little bit later. So first, some key facts. Around 4 to 5 million status epilepticus occur in the world. The incidence of the first episode in Salzburg in adults was 36.1 per 100,000 per year, with a steep increase in the elderly. Refractory status, which is a therapeutic problem, is a rare condition, 7.2, and super refractory 1.2 per 100,000 patient years. Still, the mortality is high. It's ranging between 17 and 38%, depending on several factors. Also, this is a point I will come to. Less than half of the patients have pre-existing epilepsy, most of them low serum levels of anti-seizure medicines, and more than half are acute symptomatic. The big five are important: cerebrovascular, trauma, encephalitis, meningitis, alcohol-related and toxic. So there is a consensus that status epilepticus is a special condition and not just longer seizures. So what is status then? Well, status is defined, at least we can define it now, even we don't know what it really is, but we can define it using one conceptual definition with two operational dimensions. And we say that status is a condition resulting either from the failure of mechanisms responsible for seizure termination or from the initiation of mechanisms leading to the abnormally prolonged seizures after a certain time point, with long-term consequences after another certain time point, T2, including neuronal death, neuronal injury, and alteration of neuronal networks. And there's a clear difference to usual short self-limiting seizures. When you look at that for the generalized tonic-clonic status, T1, abnormally prolongation, was set at 5 minutes, and T2, where expect that brain damage occurs, is set at 30 minutes. For other seizure types, such as focal with impairment of consciousness, T1 is set at 10 minutes, and T2 was just estimated to be around 60 minutes. And there is increasing evidence now that this is quite a good time frame. For absent status, we don't know, and we have to search for that. So there's a task to improve the knowledge there and the knowledge gap currently. So when we talk about the big clinical groups, we can say it's non-convulsive status epilepticus without coma. And then we have something which moves from the generalized tonic-clonic status over the time with electromechanical dissociation to deep coma, even without any motor phenomena. That's the comatose non-convulsive, and that's an important category. So why do we have this time frame in status epilepticus? In stroke, it's very clear, 3 hours, 4.5 hours, that we can save tissue. Here we have to avoid T2. We have to avoid the long-term consequences, which arise through continuous seizure activity, a high metabolic demand, leading to a hyperperfusion and disruption of blood-brain barrier, vasogenic edema, which can be assessed by MRI, and the shift to anaerobic metabolism if the metabolic demand exceeds the hyperperfusion, which is a compensation. Lactate accumulates, failure of sodium-potassium pumps, water influx, and cytotoxic edema, again to be visualized by MRI. And if status is reversed, then reversion of neuronal damage can occur. If not, there's a point of no return, as called by Lotman, where irreversible neuronal changes occur. So what we tend to forget usually, also something what we miss, is the systemic consequences of ongoing seizure activity, leading to lactate accumulation, hyperthermia, hypoventilation, acidosis, hypoxia, catecholaminergic storm. At the end, the patient dies in multi-organ failure. And this is what we have to put into the equation when we only focus on the brain. So I already mentioned the epidemiology with a steep increase, and how steep it is, you see in this frame. It's twice to 3 times as high as in the younger age group when we look at the elderly population. And it's higher in women as opposed to men, also an interesting observation. And in the elderly, the non-convulsive status epilepticus is a common phenomenon where we have the differential diagnosis of encephalopathy or of stroke. And sometimes it's difficult in the clinical routine process to identify these so-called stroke mimics. When we come to refractory, we don't have a lot of data. I mentioned already the incidence. There are only 2 studies, one from Finland and one from Salzburg, looking at the incidence according to the new definition of these rare diseases. But recently, a paper from the Canadian Arctic was quite shocking for me. In this region, Kivallion region, Nunavut region, they live around 1,000 to 2,000 kilometers away from the referral site. And you see the dimensions of the map. And they found much higher incidences, which are going up to 84.5 per 100,000 per year. And the number with pre-existing epilepsy went down to 16. So we might have huge geographic variations. So what types of status do we know, and are they relevant? Well, the classification is quite simple and clinically oriented according to taxonomic criteria. One is motor phenomena. With prominent motor phenomena, we have the tonic-clonic, myoclonic, focal motor, tonic, and hyperkinetic status, again with subtypes. And on the non-convulsive status epilepticus side, we have the ones which are in coma and the ones which are not in coma. This is, for example, typical absent status, or focal with impaired consciousness, or focal aphatic status, or we have some unknown, for example, the autonomic status epilepticus. So the 2 taxonomic criteria, 1, motor phenomena, 2, a degree of impairment of consciousness, are the one which we used in this classification. So is it relevant, or is it gymnastics? Well, based on this theoretical reasoning, we thought that some of the status types are more determined by the structural damage which is prevalent in the brain. For example, subtle status epilepticus or comatose non-convulsive status, whereas others, such as absent status, are purely determined by the generalized spike wave discharges, which led to the suspension of working memory, but they don't lead to structural brain damage. So when we have this hypothesis, we could assume that the mortality and the impact on the human being is different according to the different types. And here again, we have these 2 types, with prominent motor phenomena, without prominent motor phenomena. And you see the CF is the case fatality, which varies enormously. And we have the most dangerous, with a case fatality of 60%, are the ones which start with a motor phenomena and end up in coma and in stupor. So these are the comatose non-convulsive status epilepticus. Whereas the convulsive only, which you see on the left part of the slide, there is 0 case fatality. So based on that, we see that the outcome of status is associated with its semiology. The worst outcome is in the ones with impaired consciousness. The dynamics is important, and we see that these status types represent biological classes. And this has been also confirmed in a cluster analytic approach. Here for status with prominent motor symptoms, they fall into 3 clusters: electroclinical phenotypes with the EEG, and also with the different prognosis and with the different etiology, confirming that these are separate biological classes. And we did the same cluster analytic approach with non-convulsive status. There we took into the equation the impairment of consciousness according to the Glasgow Coma Score. And again, here we see 3 clusters, which are fairly well as we have it in the classification, which was a theoretical approach, but here we have a practical analysis confirming that they have a different outcome. So how do we currently approach status epilepticus? This is the scheme which most of you know, and it's derived from the generalized convulsive status epilepticus, from the Grommal status, which starts with ongoing seizure activity, sometimes in cluster seizures with prolonged seizure activity, stage 1. Once they are longer than 5 minutes or impairment of consciousness remained between the seizures, we say it's status, T1 is reached. Established status, well, you can also say this is the one which lasts a few minutes, more than 5 minutes. But we also define it as benzodiazepine refractory once we applied benzodiazepines. So the third stage is the refractory, which is refractory to 1 benzodiazepine plus and one seizure medication. And if it's ongoing, we call it super refractory or prolonged super refractory or prolonged refractory. This is, I would say, academic gymnastics. The key point is the transition from early to established and from established to refractory, where we put our emphasis. For the first stage, we have the benzodiazepines, irrelevant by which route. And for the second stage, we have anti-seizure medicines, which we should apply in a rapid, time-driven way. We have good randomized clinical trials for stage 1. We have now also good trials, and this is probably the best of that, for stage 2, for the established status epilepticus, and Jaideep Kapur is the first author of this excellent group. 50% response rate in benzodiazepine refractory, whatever you give, levetiracetam, phosphonatoin, valproic acid. So we have good guidance from our randomized class 1 trials. Also related to the side effect, there was not much difference between those 3 groups. Well, then we have treatment recommendation, and this is the one from the American Epilepsy Society, published some years ago after the ESET trial. Benzos in the first stage, anti-epileptic drugs in the second stage, and it was focused on phenytoin, valproic acid, and levetiracetam. And later, there is no clear evidence to guide, but anesthetic treatment with continuous video monitoring is done. So that's a simplification. But what are we missing? Well, there are a few things. First is, of course, let's look at the comparators. We have 3 comparators in the trial, and we took out 1 important drug or 2 important drugs, and this might be phenobarb. In this network meta-analysis, we compared, made indirect comparison, and we found that whenever phenobarbital was in the comparator arm, it was significantly better than any other drug. Good old phenobarbital, it was superior to phenytoin, valproic acid, diazepam, levetiracetam, and lacosamide in status cessation. It had more side effects, but at the end, it was more efficacious. The second point is, let's look at the dose. The dose is too low. In this observational study on more than 1,000 patients, we found that the first dose given It was benzodiazepines in 86%, but it was underdosed in 76% of generalized convulsive and in 78% of non-generalized convulsive status epilepticus. And what did we get? We get a lower response rate. If you look at the randomized controlled trial with the standard dose, you get 50 to 60% response rate with benzodiazepines. And here we achieved 40% response rate at best, and 20% with the worst dose, because these patients were underdosed. The third thing we miss is the cause. We are very good in identifying these 5 big causes. Well, that goes within a few minutes. But if we don't find the cause, then we are in trouble. And then we make an acronym and say it's NORS, New Onset Refractory Status Epilepticus. And half of the cases remain cryptogenic. Imagine, we cannot identify the cause despite these serious conditions. And the treatment protocol we have is quite erratic. It's dependent on the individual doctors. There's no standardized protocol. Most of the studies, most of the centers use infectious disease tests or autoimmune panel. Why is it important? Because you treat it in a different way. You treat it with anti-immune or with immune modulating treatments, and Annamaria Vezzani gives you another good reason why you should do that. The third point is the EEG. We're very proud to have excellent EEG criteria, the so-called Salzburg EEG criteria, where we look at the frequency of discharges and say 2.5 Hertz, above or below is the relevant border. But many studies, and this is one of them, show that even discharges at a lower rate than 2.5 Hertz have an increased metabolic demand, which goes in a linear fashion up the higher the frequency is. But if we have a lower frequency, it doesn't mean that it's not status. And if we go even to the cortex, we see cortical spreading depolarizations, which is an interesting phenomenon and which is highly associated with an increased mortality and morbidity in severely brain injured patients, for example, subarachnoidal bleeding. If we put that all together into one equation, you have on one side, you have the burden of the epileptic activity after time point T2. On the other hand, you have the burden of the structural damage of the brain. In addition, you load the patient with potentially toxic drugs, so you have also a burden of treatment. And depending on how much you can win, you can put this into a general equation to make the treatment decisions. But there are unknowns, which I just explained to you, for example, the cortical spreading depressions or the EEG criteria. Here, the last 2 slides. One shows you lateralized periodic discharges at the frequency of, let's say, 1 per second. Yeah. And is it status or not? According to the criteria, it's not status. When you look at the MRI, you see, of course, structural changes, but what you see is in the left hippocampus and hyperintensity in this patient not fulfilling these criteria. So it's a clear sign that there is, of course, something going on. And that's the structural imaging, but let's go to the functional imaging. Here a patient, on the left you see patient in non-convulsive status epilepticus, and on the right, the interictal state. Does he fulfill the criteria, the Salzburg criteria? No. But if you look at the MRI, there's a clear hyperperfusion and also potential, this is a bilateral hyperperfusion in the basal ganglia and bifrontally, which was reversible after treatment of the status epilepticus. And this is the third dimension where I think it's important to know. To conclude, epidemiology status is one of the most common emergencies, but there's a huge geographic variations which we have to further explore, whether these are the causes or whether this is the variation in diagnostics. It will definitely increase with the elderly. The new definition guides earlier appropriate treatment and provides a framework for the escalation. The unknowns are, of course, other status types like hyperkinetic, where we don't know T1 and T2, something we have to explore. The positive thing is we know that semiology, etiology, and EEG reflect biological classes, which go together with treatment success and with prognosis and outcome. So semiology is important. We have excellent high-class randomized controlled trials, and we are now embarking on producing clinical practice guidelines in Europe, in the US. They are in statu nascendi. We are good in identifying the common causes, but bad in identifying the uncommon causes. There are no common data elements for collaborative studies. This is what we want to achieve in the near future. But what are we missing? I think number one, in the clinical practice, it's non-adherence to guidelines with widespread underdosing. Number two, our diagnosis of non-convulsive status is biased towards EEG. So we need a third dimension, which is MRI and perfusion imaging, in addition to EEG and the clinical information. The impact of burden concept should look what you can win with forced treatment and what you don't win with a forced treatment, such as hypoxic brain injury, and also consider the burden of treatment in addition to the brain damage and the ongoing excitotoxicity. So if you want to hear more, there will be a conference which we moved from April to September 2022. Looking forward to seeing you. Thank you very much.
Eugen, thank you very much for an incredibly comprehensive and also a very, in a way, slightly controversial talk. I mean, one of the interesting things that you brought up whilst we're waiting for the questions to arrive, one of the interesting things that you brought up was the fact that phenobarbital may well be a superior drug and we're not using it. And do you think we ought to be using it? Do you think we're missing a trick there? There's always been concerns that with benzodiazepines you get considerable respiratory depression, but that's rather anecdotal, I think, isn't it?
Yeah, so I think that's important, and I changed my mind completely there in this point. In 2007, when we were discussing for the first time the ESET trial or randomized controlled trial, Jaideep, you know exactly, then of course, I thought that no one uses phenobarbital anymore. Of course, many people used it, but in Austria, it was not used anymore for status epilepticus. So, but when we looked at the older studies and found the result, I think it's time to include such a drug also in the clinical trials. Otherwise, we will end up in using levetiracetam, valproic acid, and phosphonatoin for the next 25 years, and maybe miss something powerful, which we could also use at the beginning. I think the critical point is, do we harm patients? What is the risk-benefit ratio? We can only answer that with the trial.
Okay, an excellent question has come in from Greg Scott here, actually. So he said, thanks for the excellent talk, but do you think there are other perhaps quantitative EEG measures that could help us gauge the burden of status epilepticus and also help guide treatment? I mean, there would be a problem, for example, in doing both MRI and EEG before we decide to treat people with non-convulsive status epilepticus. And if we could just have EEG, but analyzed in a different way, then perhaps that could guide treatment, not only what treatment to use, but also when to use it.
Yes, very good, excellent point. So first of all, it's a comment. So we don't do the MRI before we treat the patient. So we treat the patients according to what we think is good, give anti-epileptic drugs. The EEG is okay, it's not ongoing status epilepticus, but then you still see activity hyperperfusion in the MRI, and you see the brain damage in the MRI. This is why we do it. So to use MRI as a guide for treatment will not work. I fully agree with you. There are attempts in two ways. First of all is to reduce the number of electrodes and have a quick application where we are with the EEG to guide the treatment. And the second is to use artificial intelligence to make a quick EEG and have more information to dig in deeper into the signals to guide treatment. And that's a very important point. And I think this is something important what we should pursue in the future.
And there's another excellent question that's come in from Abdul Basit Siddiq, but also Greg Scott has also got a second question that he's put it with, and putting those together really is about the underdiagnosis of non-convulsive status epilepticus. And do you think that quite a lot of patients who are labeled as delirium or encephalopathy may well be having non-convulsive status epilepticus and we're missing them? And then, of course, there's just the idea of being able to get hold of an urgent EEG. I mean, that's not often possible. And do you think we're just missing in many district general hospitals non-convulsive status epilepticus?
The answer is yes. I think we are missing many cases in general hospitals or district hospitals. That's a problem. I would say to have an EEG in every emergency unit is possible. It's cheap. It's easy to apply. It's reliable, and it gives you a huge bunch of information which you can use for further treatment. With MRI and imaging, it's of course much more difficult. But EEG, if we look at the health economics, it's not an expensive investigation. It became old-fashioned, so people didn't use it anymore because they thought that when you have a computerized tomography, that's it. But I think it has to be reinstalled, even in smaller hospitals. Simple, easy to apply, quick EEG will improve healthcare.
I think one of the problems there is, of course, the interpretation, isn't it? I mean, that's going to be more of a challenge than actually doing the investigation.
There is a big movement now towards standardization of interpretation of signals. Teaching is one thing. Humans are always a problem, and they deviate not only from the guidelines, but also from the terminology, from the interpretation. So artificial intelligence, it's the magic word, will have some improvement. And if you go back and think on the ECG, also there, when you started to interpret it automatically, doctors started to improve their knowledge. So I think this is something which is coming soon, that we have automatic interpretation. And then, of course, the doctor has to think and accept it or reject it.
Right. And there's another excellent question, which is from Niroshan Giacomo, who asks, he says, great talk, but he asks, I think this is for the third line AED. So this would be, we have evidence for obviously benzodiazepines, and then there's evidence that levetiracetam, valproate, and phenytoin are equally efficacious. But what after that? Is there guidance on what AED we should be using after that?
No, there is no guidance on that. One thing is time. So if you lose a lot of time by using phenytoin, not phosphoenitoin, then you probably miss something because you're going on deeper into T2 and brain damage. And so you should proceed as early as possible to anesthesia. And there is no guidance which one is the best. So I think this is something which comes soon in clinical trials.
Okay, well, I think we just have to finish there because of time. But thank you very much for the excellent talk, Eugen. And we move on to, I think, the first data blitz, which will be Claire O'Connor. Claire.
Hello, my name is Claire O'Connor, and I'm a final year PhD student in the Campbell Lab in Trinity College, Dublin. I would firstly like to thank the Brain Conference Organising Committee for inviting me here today to present some of my work as a quick data blitz. We have shown a clear link between decreased Claudin-5 expression and numerous neurological disorders such as psychosis and epilepsy. Claudin-5 is significantly disrupted in surgically resected tissue from patients with epilepsy, with the tissue showing a decrease in both the pattern and intensity of Claudin-5 staining relative to CD31. Moreover, DCE MRI imaging revealed numerous sites of gadolinium extravasation in a patient with temporal lobe epilepsy, which is drastically different to the image's post-surgical resection, showing that resolving the barrier can restore function. Therefore, we wanted to design and optimize a gene therapy-based approach using an AAV vector to restore Claudin-5 expression at the blood-brain barrier. A plasmid was designed to express mouse Claudin-5 under the control of the endothelial cell-specific promoter ICAM2, and this was then incorporated into an AAV9 vector. Through the characterization and optimization of this AAV in vivo, I found that an intrahippocampal injection at a dose of 2 × 10⁻10 viral genomes per ml was sufficient to result in a significant increase in Claudin-5 expression, which was analyzed through both qPCR and Western blot. The rescue potential of the AAV was examined through 2 distinct mouse models, both which express at least 50% less Claudin-5, and through behavioral characterization, both display distinct behavioral deficits. The Claudin-5 Flox Tie2-Cree model is a newly established model in our lab. It is a transgenic mouse that is obtained by crossing the Claudin Flox mouse with the Tie2-Cree model. The resulting Cree-positive animals have only one copy of the Claudin-5 allele and so produce 50% less mRNA and protein. It is a behavioral phenotype that includes PPI, pre-pulse inhibition deficits, compromised memory, and anxiety-related behaviors. 3 weeks post bilateral intrahippocampal AAV administration, there were clear behavioral changes noted in these Cree-positive animals. The Y maze, which examines working spatial memory, noted a reduced number of errors in the Cree-positive mice when they were treated with the AAV Claudin-5. The avoidance to social interaction noted in the Cree-positive mice was also reduced following treatment with the Claudin-5 AAV, and the significant deficits in PPI that were noted in the untreated Cree-positive mice were significantly improved following AAV administration. These findings show that the overexpression of Claudin-5 has the potential to attenuate some of the deficits noted in this model. Next, our Claudin-5 160 mouse is a doxycycline-inducible knockdown model. Continued knockdown of Claudin-5 in this model results in seizures and death. These mice were again bilaterally injected into the hippocampus with the AAV and allowed 1 week to recover. Following this, they were put on doxycycline for 2 weeks before behavioral characterization was started. The survival curve indicates clearly a distinct rescue with overexpression of Claudin-5 through AAV administration, extending their survival rate by approximately 1 week on average in comparison to their control AAV litter mates. So this is just a very quick overview of some of the work that I have carried out using this blood-brain barrier restoring AAV. I thank you all so much for taking the time to listen to me, and I welcome any questions or comments. Thank you.
Claire, thank you very much. That was a very clear and very interesting talk. Just whilst waiting for the questions, because there's some delay, what do you think actually regulates Claudin-5, or do you know what regulates Claudin-5 and why it may be decreased?
Well, do you know what the blood-brain barrier and Claudin-5 as a whole is such a dynamic area. Claudin-5 itself does seem to be affected by circadian rhythms and everything. So there's a multitude of things that are probably controlling it, but it's definitely something that is very much downregulated after insult. So things like SE or just a physical insult, stroke, it's very much damaged in any kind of insult.
Okay, and which is fascinating. And the other thing, obviously, is at the other end, when Claudin-5 does get downregulated and you get leakage to the blood-brain barrier, you showed a lot of the behavioral things that seem to change. Do you know what underpins those? Is there a common mechanism, or do you think there are a number of different mechanisms underlying those changes?
I think with behavior, it's always generally quite complicated. It's never usually one underpinning thing, but I do think because obviously the hippocampus is involved in so many learning and memory tasks, everything like that, that when damage is done to certain areas, then absolutely there's a multitude of things that are probably going on, absolutely. Okay, that's brilliant. Well, thank you very much, Claire. That was really excellent. And we'll move now on to our next talk, which is the neurobiology talk, which is a great pleasure to introduce Professor Annamaria Vezzani, who's head of experimental neurology at the Mario Negri Institute of Pharmacology, and is a leading light in understanding of inflammation and reactive oxygen species in epilepsy. So, Annamaria.
Good afternoon. Thank you very much to the organizers for inviting me to attend this session and talk about the role of neuroinflammation and reactive oxygen species in status epilepticus. The animal models of status epilepticus have been instrumental to reveal the generation of reactive oxygen species and neuroinflammatory mediators by multiple cellular sources in brain parenchyma, which includes neurons, activated glial cells, and cell components of the blood-brain barrier. The interventional studies in animal models have revealed that these processes are not a mere epiphenomenon of the pathology and of the seizures, but they may contribute importantly to the pathological consequences. So in this presentation, I will show you examples of the expression of inflammatory and oxidative stress markers during and after status epilepticus, both in animal models and in human tissue, in human brain tissue. I will also show you examples of redox-based and anti-inflammatory treatments on both acute status epilepticus and its sequelae, and some examples of clinical translation. So the experimental studies have been mainly done in models of de novo status epilepticus in healthy rodents, both mature and immature animals, where status epilepticus was induced by either electrical stimulation of limbic brain areas or by chemoconvulsive drugs injections either intraparenchymally in the brain or systemically, or status epilepticus induced by hyperthermia. The expression studies and interventional studies have been done in the acute phases of status epilepticus, but also with a special attention to the subacute and chronic outcomes, which includes mortality, neuronal cell loss, neurological comorbidities, and also epileptogenesis, since in most of these models, spontaneous seizures arise weeks to days to weeks after status epilepticus, depending on the experimental model. So we know that physiological concentrations of reactive oxygen species and neuroinflammatory mediators are very important for a balanced neurotransmission, neuroplasticity, and also for tissue homeostasis. However, if there is an excessive production of these species and also inflammatory mediators, this may lead to neuropathological consequences. Neuroinflammation and oxidative stress co-occur in status epilepticus, both in animal models and in patients. And these are two phenomena that are strictly linked. Indeed, the activation of innate immune mechanisms, such as the activation of toll-like receptors, may induce the production of ROS from mitochondria or from enzymes such as NADPH oxidases that are cytoplasmatic membrane-bound enzymes. Indeed, the production of ROS from mitochondria represents an early source of reactive oxygen species during the initial phases of status epilepticus. Then, when mitochondria function fails because of membrane depolarization and accumulation of intraorganelle calcium, there is NOx enzymes that sustain the production of ROS. Importantly, NF-κB is a transcriptional factor that has a redox sensitivity, and it is very important for the transcriptional induction of inflammatory genes. Another point of contact is the activation of thioredoxins that are oxidoreductases that are activated during oxidative stress because there is an uncoupling of this thioredoxin binding protein. This protein, upon its release from the enzyme, is an activator of the inflammasome, therefore leading to the induction, biosynthesis, and release of interleukin-1 beta and high mobility group BOX1 that are two inflammatory ictogenic molecules. Indeed, HMGB1 is another protein that links oxidative stress to neuroinflammation. It is bound to nuclei in physiological conditions where it regulates the transcription of inflammatory genes. During status epilepticus and also following acute brain injuries, the molecule leaves the nucleus and goes to the cytoplasm. From this location can be extracellular release, and this occurs from neurons and glial cells, and also from constituents of the microvessels. When it is in the extracellular space, the function of HMGB1 is governed by the redox state of the tissue. When there is oxidative stress, the molecule is oxidated at two cysteine residues, forming the so-called disulfide HMGB1. In this conformation, the molecule activates the inflammatory innate immune receptors, like receptor 4 in brain parenchyma, giving rise to neuroinflammation and contributing to neuronal cell loss, seizures, and neurological comorbidities. Interestingly, several inflammatory and oxidative stress mediators or related molecules can be measured in the bloodstream. Therefore, they may represent a potential biomarker of these processes in the brain. This is an example of induction of an inflammatory response in the brain tissue in limbic areas during status epilepticus provoked in adult animals by a chemoconvulsive compound or by electrical stimulation of the hippocampus. This is exemplified here by interleukin-1 beta, but also other cytokines with ectogenic properties are induced to a similar extent. The induction of these transcripts and protein is very rapid during status epilepticus, has a long persistence, and importantly has a poor resolution. This is depicted here by the induction of IL-1 receptor antagonist, that is an anti-inflammatory molecules that block the IL-1 beta signaling. This molecule is induced during status at a lower extent than the pro-inflammatory counterpart. However, to efficiently block the IL-1 beta signaling, it should be induced in large excess. There is also clinical evidence in NORSE patients for intrinsic inefficacy of circulating IL-1 array for blocking the IL-1 beta signaling. There is also evidence for the translocation, cytoplasmatic translocation and induction of HMGB1 in the hippocampal tissue during status epilepticus in animal models in different cell populations. Oxidative stress is also induced very rapidly, as shown here by real-time measurements with microdialysis techniques of hydrogen peroxide production in the hippocampus during status epilepticus in animal models. We also have observed a long persistence of markers for oxidative stress, as shown here by the ratio between the oxidized and reduced glutathione, that is a marker of oxidative stress, that persists 4 and 14 days post-status epilepticus in a model where status epilepticus is induced by electrical stimulation. Other colleagues in the literature have indeed confirmed this long persistence, and when assessing the brain tissue up to 3 months after the induction of status epilepticus, they found a reduced GSH-GSSG ratio indicative of oxidative stress, increased production of ROS, and this chronic perturbation of the redox status of the brain tissue is associated with evidence for macromolecular oxidative damage. Neuroinflammation and oxidative stress do not occur only in animal models, but also in human tissue from patients who died during status epilepticus. Here is a representation of the histological assessment of various markers for oxidative stress and neuroinflammation in the hippocampus of a rat that is exposed to electrical status stimulation. To status epilepticus induced by electrical stimulation. And this induction occurs in brain parenchyma cells, which includes neurons, glial cells, and endothelial cells of the blood-brain barrier. A very similar pattern is observed in patients who died in status epilepticus in histologically examined brain tissue. And still you have induction in parenchymal brain cells of markers of oxidative stress and neuroinflammation. This is an example from a pediatric patient diagnosed with FIRS who died in intensive care unit after 27 days of continuous status epilepticus. And the analysis of brain tissue revealed activation of astrocytes and microglia, extravasation of serum albumin in the brain parenchyma, which is a marker for blood-brain barrier damage, and also induction of ectogenic inflammatory cytokines such as interleukin-1 beta and HMGB1 in brain parenchymal cells. In patients with NORSE, there is intrathecal overproduction of pro-inflammatory cytokine and chemokines, several of which have ectogenic properties in animal models, and there is also evidence for an increase in the CSF of pediatric patients with status epilepticus of markers of oxidative DNA damage. Increased markers of oxidative stress can also be measured in the blood of patients with status epilepticus, as highlighted here by an increase in oxidative stress mediators in blood as compared to a control population, which is associated with the evidence of a decrease in production of antioxidant defense molecules, both enzymatic and non-enzymatic. So what about the treatments? I would like to depict these effects of anakinra, that is the IL-1 receptor antagonist, and in its human recombinant form is a drug used in humans for inflammatory and autoimmune disorders. In animal models of status epilepticus, anakinra was able to reduce the incidence and also the severity of status epilepticus, to improve neuronal survival in forebrain regions, and notably also to enhance the efficacy of diazepam in inhibiting status epilepticus in a status model that is otherwise refractory to benzodiazepines. So this evidence led to the first attempt of clinical translation of findings from animal models to the human pathology with the use of anakinra in several case reports of NORSE and FIRE patients. And this is a retrospective analysis of 25 children. And these studies indicate signs of therapeutic effects with a decrease in the intensive care unit and hospitalization time, decrease mechanical ventilation, and also decrease seizure recurrence. The treatments in animal models have highlighted new druggable targets for reducing status epilepticus. One class of compounds are the inhibitors of monoacylglycerol lipase. These are small molecule, brain-penetrant molecule that can inhibit MAGL, that is the main biosynthetic enzyme for the biosynthesis of arachidonic acid in the brain. By blocking MAGL, there is a reduction in the prostanoid cascade, which leads to anti-inflammatory effects, and simultaneously an increase in the precursor of arachidonic acid 2-AG, that is an endocannabinoid, therefore promoting the endocannabinoid tone, that is anti-inflammatory per se, and also reduces glutamate release from excitatory terminals. We use a model of benzodiazepine refractory status epilepticus. This is the vehicle-treated cohort, and these are the number of spikes evolving during status epilepticus. If we treat a parallel cohort of mice with the MAGL inhibitor, there is a rapid reduction in the duration of status epilepticus. Importantly, if we treat the animals with the ketogenic diet inducing ketosis, and then treat the animals with the MAGL inhibitor when provoking status epilepticus, this cohort of animals virtually did not develop status epilepticus as compared to the vehicle control. Another class of compounds are the P2X7 receptor blockers. They prevent the ATP-induced activation of these receptors. ATP is a dangerous signal released from brain parenchymal cells during status epilepticus, and the blockade of these receptors impair the inflammasome activation and therefore the release of HMGB1 and interleukin-1 beta. These antagonists that penetrate the brain reduce significantly the duration and the severity of status epilepticus in animal models. And recently, we also highlighted the contribution of the chemokine IL-8 in the duration of status epilepticus in the animals. This is a chemokine that is significantly induced in the CSF of patients with new onset refractory status epilepticus, and using reparixin that blocks the activation of its receptors, it was possible to significantly reduce the duration of status epilepticus and also the incidence of acute symptomatic seizures developing in the next 2 days post-status epilepticus, and notably also the spontaneous recurrent seizures that arise during in the aftermath of status epilepticus. Oxidative stress and neuroinflammation can also contribute to status epilepticus associated mortality and neuronal cell loss. This is an antioxidant drug that, as you can see, can reduce the mortality rate that develops in the animals following pilocarpine-induced status epilepticus. And a similar rescue from mortality is induced in animals if they are injected with EP2 receptor antagonists that block the activation of these receptors by prostaglandin E2. These drugs also allow a faster weight recovery of the animals post-status epilepticus, and both antioxidant and specific anti-inflammatory drugs may rescue cognitive deficits that develop in status epilepticus exposed animals. This is a test that is impaired and reflects impairment in recognition memory, and the animal's impairment is prevented or rescued by the action of anti-inflammatory or antioxidant drugs. Also, neuronal cell loss in the hippocampus, depicted here by the black bars, is significantly reduced by anti-inflammatory but also by antioxidant treatments. And finally, what about the long-term consequences of status epilepticus? In the animal models, this leads to the epilepsy development. And these are nice data from Matthew Walker and colleagues, where they use a small inhibitor antioxidant drugs that is brain penetrant and promotes the biosynthesis of detoxification and antioxidant enzymes by promoting the translocation of transcriptional factor and RF2. If the drug is given for a few days post-status epilepticus, then the treated animals, that are the blue bars, develop significantly reduced seizures as compared to the vehicle controls. The drug is also effective in mice, in rats, in chronic epileptic rats that have already established seizures. Notably, even more significant therapeutic effects are attained in the same model by a combination of the previous drug with an inhibitor of NADPH oxidase. These are the blue bars, where the decrease in seizures is significantly more pronounced as compared to each drug given alone. We found similar results by using a combination in a similar model of N-acetylcysteine, that is a precursor of glutathione, and sulforaphane, that, like the small inhibitor of oxidative stress shown before, promotes the transcription of detoxification and antioxidant enzymes. And similar disease modification effect can also be attained using specific anti-inflammatory drugs, either alone or in combination. So to conclude, the preclinical studies in animal models of status epilepticus and clinical observation show that both neuroinflammation and oxidative stress occur during status epilepticus and persist thereafter. There are markers that can be tracked in blood of both neuroinflammation and oxidative stress that may offer an opportunity for developing biomarkers. Anti-inflammatory drugs interfering with the IL-1 beta pathway, the P2X7 receptors or the IL-8 receptors may control refractory status epilepticus in animal models, therefore they are promising drug candidates for a clinical translation. And importantly, anti-inflammatory and antioxidant drugs may also significantly improve neurological sequelae and the ensuing epilepsy in the animal models of status epilepticus. So I would like to stop here by thanking you for your attention, and also the people in the lab that have contributed to part of the study that I have presented, and also our major sources of support. Thank you.
Oh, thank you, Annamaria. That was a absolutely fantastic talk covering a lot of ground. We have a limited time for questions, but a very important question has come in from Ramon Diaz-Aristia, and says, excellent talk. He wondered what are the leading candidate biomarkers of seizure-related oxidative stress and neuroinflammation? And just adding on to that, do you think that that could also perhaps, or those could also perhaps guide treatment?
Yes, there is evidence in the literature that, and we also found out that the reduced and oxidized glutathione can be good markers of brain oxidative stress. And also Matthew himself and others have shown that there is a combination of markers that are classified as total antioxidant capacity that are decreased in condition of oxidative stress and can be relatively easily measured in the blood by a kind of ELISA kits. So these are the most accredited or validated, so to say, biomarkers so far that I know. It would be nice to measure disulfide HMGB1, but unfortunately there is no rapid method for detection of the oxidized form of this circulating molecule. And of course, if one can indeed identify and validate biomarkers for oxidative stress, they would help, I guess, to select or stratify the patient populations that that would mostly benefit from such treatments.
Okay, that's excellent. I think we are just a bit running short of time, so perhaps if there are other questions we could have those at the end. So really we're moving back onto the data blitz, and it's a great pleasure that we're going to have Sophie Adler, who's going to present her few-minute talk.
Thank you for the opportunity to present Interpretable Automated Detection of Focal Cortical Dysplasias on MRI, a MELD study. Drug-resistant epilepsy is often caused by focal cortical dysplasias, and these are notoriously difficult to identify on structural MRI, but are amenable to surgical resection. We wanted to develop an open-source, interpretable machine learning algorithm to automatically identify focal cortical dysplasias on heterogeneous, clinically acquired structural MRI data from epilepsy surgery centers worldwide. We had 1,015 participants from 22 epilepsy surgery centers, including both pediatric and adult participants. Our analysis pipeline involved at the site level running free surfer reconstructions, extraction of surface-based features, manual lesion masking, and registration to a template space. We then performed multi-center harmonization to account for site and scanner-based differences and 3 stages of normalization. This provided the data set that we could use to train and develop our classifier. We split our cohort 50-50 into a train and test cohort, and the train cohort was used for all classifier optimization and development, and the test cohort was left for evaluation. A multi-layer perceptron was used as our classifier, and I'll show you some of the outputs now. So on the left, you have 2 individual patient reports. Patient 1, in the top, you can see over here where the predicted lesion is on the inflated surface, and then below, it's projected back into native space. In panel B, you can see what the features were within that predicted lesion and the saliency, so how important they were to the classifier. In this example, the predicted lesion is mainly characterized by gray matter flare hypointensity, and this is what the classifier is using to drive its prediction. Patient 2 is an example of a patient with only T1 data available. Again, you can see where the classifier predicted on the inflated surface and in the MRI space. And you can see that this lesion was mainly characterized by decreased gray-white contrast, so blurring of the gray-white matter boundary, and increased intrinsic curvature, so an abnormal folding pattern. Overall, after including a border zone around lesions to account for uncertainty around manually delineated lesion masks, we have an overall sensitivity of 67%, specificity of 54%, and on a restricted cohort of seizure-free patients with SCD type 2B who had both T1 and flare data available, our sensitivity is 85%. In conclusion, we present a robust and interpretable machine learning algorithm for automated detection of focal cortical dysplasias that could be used as a research adjunct in the pre-surgical evaluation of patients with epilepsy to improve confidence in the identification of subtle MRI lesions. All codes available at our GitHub, our manuscripts available as a preprint on medRxiv, and we're also starting a MELD focal epilepsies project, so do get in contact for more information. Thank you.
Sophie, thank you very much for that very clear and an excellent talk, very interesting. Just whilst questions come in, I've got a number of questions myself. So the first is this technique sort of more sensitive and more specific over in certain brain areas compared to others, or did you find that it was generally similar across the brain?
So in general, we haven't seen an effective location as to the sensitivity. We do in general find though that insular lesions are more challenging to detect, probably because they're already it's quite a thick area of cortex, and so it's harder to disentangle true positives from false positives in that area.
And if I understood you correctly, the specificity is actually quite low. So this is just have to be a guide, is it? And then we'd have to go and look and study that region to make sure there's an abnormality there.
Yes, that's correct. So I think the biggest challenge with machine learning algorithms for automated detection of epilepsy pathologies on MRI is specificity. It's a common problem, false positives, and where you choose your threshold very much affects your sensitivity and your specificity. And what we get is an average of 2 clusters per patient. So in most cases, we're identifying or hopefully identifying the lesion, but we'll get another area identified. So this is very much an adjunct that you would go back to your radiologist and you would say, this algorithm has identified these 2 areas. Can you go back to the scans? Do any of them look likely? We can tell you that the classifier is using the thickness and the intensity at this point. Do those things look abnormal, or could this be a motion artifact or another artifact that's driving this? So it's very much to be used in conjunction with a radiologist.
Excellent. Well, thank you very much indeed for a really excellent talk. And that leads us to the last talk of this session. Hope he doesn't mind being called the cherry on the cake. And that's Professor Jaideep Kapur, who's the Eugen Mayer III Professor of Neuroscience and Neurology at the University of Virginia.
Why does status epilepticus become drug resistant? Let us discuss this using a patient with status epilepticus. A 35-year-old man at a local shop is witnessed to have left arm shaking followed by a generalized convulsion. The convulsions continue and an ambulance is called. The emergency medical personnel arrive at the scene about 12 minutes later and seizures are continuing. Emergency personnel take about 4 minutes to start an intravenous line and then administer 2 milligrams of lorazepam. When the patient arrives in the emergency department, seizures continue and another round of 2 milligram lorazepam was given. Let us explore whether this was the best treatment our patient could have received. If we look at the treatment guidelines for status epilepticus, what we notice is that the best initial treatment of status epilepticus is either intramuscular midazolam or intravenous lorazepam or intravenous diazepam. Note the doses of these 3 drugs: 10 milligram of midazolam, 10 milligram of diazepam, and 4 milligram of lorazepam. Our patient received 2 milligrams of lorazepam after a delay of 4 minutes. Could the emergency personnel have chosen to give him intramuscular midazolam 10 milligrams right at that spot, and would that have made a difference? And this question was explored in the intramuscular midazolam versus intravenous lorazepam clinical trial led by Robert Silbergreit and Dan Lowenstein and others. They enrolled approximately 900 subjects across the United States, about 450 in each arm, and then analyzed the result. This trial was designed as a non-inferiority trial. That is, the investigators wanted to test whether intramuscular midazolam was at least as good as intravenous lorazepam. In fact, what they found at the end of the trial was that intramuscular midazolam crossed the non-inferiority boundary. That is, it was more than 10% effective than IV lorazepam. More than 73% of patients treated with intramuscular midazolam responded to therapy, in contrast to 63% with intravenous lorazepam. This result was also reinforced by the fact that intramuscular midazolam had a higher rate of discharge from emergency department compared to group treated with intravenous lorazepam. And the intubation rate and rate of recurrent seizures were similar. Why does this difference occur? The authors investigated time to administration of the drug in great detail. They looked from time from active treatment to convulsions. Actually, midazolam was slower, but time from opening the box to giving to cessation to stopping seizures, midazolam was much better. In fact, time from opening the box to administering the drug, midazolam was much faster. In fact, there's a 3-minute time delay between giving that intramuscular midazolam compared to intravenous lorazepam. Time it takes to start an intravenous drug, just that 3-minute difference made a difference in outcomes, where two equally effective drugs, one was better than the other simply because it could be administered faster. So the first lesson of this trial is that time in treatment of status epilepticus is brain. Every minute that there is a delay in treatment of status epilepticus, it is likely to become refractory. Why does status epilepticus become refractory with passage of time? You have to understand this by looking at the pathophysiology of status epilepticus. And understand that there is one structure that is most commonly affected by status epilepticus, that is the mesial temporal structure called the hippocampus. This is data from febrile status epilepticus trial of Shlomo Shinar and Daryl Lewis and others, and looking at MRI of children who had febrile status epilepticus and compared to febrile seizures, 11% of these children had injury to the hippocampus, increased T2 signal, and some of them went on to develop hippocampal sclerosis a year after that. So why the hippocampus gets injured during status epilepticus? Hippocampus receives its primary input from the entorhinal cortex, which itself receives input from all parts of the brain. Remember, the primary function of the hippocampus is to help encode memories. In order to encode memories, it has to have inputs from all over the brain, and those are funneled to the entorhinal cortex. This information from entorhinal cortex is filtered or gated by dentate gyrus, which allows only the most salient information to enter CA3 and CA1 region of the hippocampus. This gating function of dentate gyrus is maintained by very strong inhibition, a barrage of inhibitory synaptic input onto granule cells shown here. Also a form of extrasynaptic inhibition called tonic inhibition. And finally, a very hyperpolarized chloride equilibrium potential maintained by chloride transporters KCC2 and KCC1, which is pumping chloride out and making GABA hyperpolarizing. So strong GABAergic inhibition reinforced by inhibitory effect of GABA. Both these collapse during status epilepticus. First, I want to show you that hippocampus is greatly activated during status epilepticus. Entorhinal cortex is active, and dentate gyrus, CA3 and CA1 regions of the hippocampus. These pictures are taken from mice that have undergone status epilepticus. These are genetically modified mice that express a red protein called TD tomato under the control of an early imager gene promoter called CFOS. And red is where seizure activity has been spreading. Note dentate gyrus here. It is very silent when in normal states, less than 1% of granule cells are active at any time. But when status epilepticus begins, this dentate gate, which is stopping most of the activity from entering the hippocampus, becomes very active. 30% of granule cells become active right at the onset of status epilepticus and continue to be active throughout status epilepticus. How does this gate break down? As I mentioned, GABAergic inhibition is very strongly maintaining this dentate gate. And what happens during status epilepticus is this GABAergic inhibition collapses due to two reasons. One, the number of GABAergic receptors at the synapse reduces, and this is shown in the smaller synaptic currents. So note large synaptic currents in controlled granule cells and lot smaller synaptic currents in animals that have undergone status epilepticus. This itself happens because GABA A receptors get internalized due to status epilepticus and increased neuronal activity. And this internalization, this trafficking of GABAergic receptors is responsible for reduced GABAergic inhibition. Second change that happens is that as seizures occur, the chloride transporter NKCC1 is also endocytosed. That is, the capability for the cell to pump out chloride from intracellular space gets reduced as NKCC1 gets internalized due to phosphorylation, and chloride builds up, and that results in high intracellular chloride and development of depolarizing GABAergic inhibition, and that is quite important in collapse of GABAergic inhibition during status epilepticus. Net result of this collapsing GABAergic inhibition is decreased sensitivity to benzodiazepines. What we saw in the Rampart trial is also seen in experimental animals, where if you treat status epilepticus at the very beginning, within 5 minutes of onset of seizures, you get within 10 minutes of onset of seizures, you get very good response. But if you wait for another half an hour, the response to a benzodiazepine treatment is reduced, in fact, reduced approximately tenfold. And this observation made years ago in experimental animals has been now confirmed in humans. When benzodiazepines fail, what do? What we do currently is use one of the three anticonvulsants, and these are results of established status epilepticus treatment trial. We either use levetiracetam or fosphenytoin and valproate. And note that what the ESET trial showed was that all three drugs are effective less than 50%. This is a disappointing result in that we would like to see most people, if not 70, 80% of those who have failed benzodiazepines to respond to second-line agents. Why do these drugs fail? I would argue that these drugs fail because they are anti-seizure medications. These are not anti-status epilepticus medications. These are not designed to break the vicious cycle of status epilepticus where seizures beget more seizures. Here is what happens once the dentate gate breaks down, when the T1 period is ended and we have what is T2 period where neuronal injury occurs. The neuronal injury during status epilepticus occurs in CA3, CA1 region because dentate gyrus is no longer stopping neuronal activity, which is bombarding these structures. And you can see cell loss here shown in green in CA3, CA1 region of the hippocampus, while dentate gyrus granule cells in red are intact, but these cells distal to dentate gyrus die in status epilepticus. How can we prevent development of cell death and cell loss? And this is a classical observation made by Denny Fujikawa in mid-1990s that has been amply confirmed by multiple investigators in the last 30 years, which is to show that if you use an NMDA receptor antagonist, ketamine, early in status epilepticus, you can protect cells. So in panel A and C, you see dying cells, pycnotic nuclei in CA1 region, in B and D, you've animals that were treated with either ketamine or another NMDA receptor antagonist early in status epilepticus to prevent cell loss and cell death. So we can prevent injury to neurons during status epilepticus using an NMDA receptors antagonist, ketamine, and ketamine is well available in our emergency departments. It's actually available all over the world. It's one of the cheapest medications. Why do NMDA receptor antagonists treat status epilepticus? NMDA receptor gets activated during seizures and status epilepticus. They let in calcium. When calcium enters neurons, it activates multiple second messenger system. These kinases and phosphatases have multiple effects. One of them is to internalize GABA A receptors, that as I was explaining to you. Others is to cause insertion of AMPA receptors and enhance excitatory transmission. Both these effects are occurring in part through an NMDA receptor. So an NMDA receptor is acting as a master switch in sustaining status epilepticus. And this is further reinforced by animal studies, both done here, this is from our lab and from Claude Vosterlain's lab. If you combine ketamine, if you use ketamine or diazepam alone, animals don't respond. But when you combine ketamine and diazepam for treatment of benzodiazepine refractory status epilepticus, what you find is that you can treat most of the patients, most of the experimental animals with this drug combination. And Claude has done a series of studies to demonstrate that. Based on these data, we are proposing to do ketamine for established status epilepticus treatment trial, hopefully next year or two. The same group of individuals who worked on established status epilepticus treatment trial. And what we plan to do is to enroll subjects who are having generalized tonic-clonic seizures, receive adequate doses of benzodiazepines, continue to have seizures, are 1 year or older, and then they get enrolled as long as they don't meet exclusion criteria, which are listed here. And then these patients will receive levetiracetam, 60 milligram per kilogram or 4.5 grams, either alone with a placebo or with 1 milligram per kilogram ketamine or with 3 milligrams per kilogram of ketamine. And then at 15 minutes, we'll assess whether their seizures have stopped, both by EEG and clinical evaluation. And at 60 minutes, we'll see whether they're improving consciousness, whether consciousness doesn't improve, but seizures have ended, whether consciousness has not improved and they required intubation or other medications in the interim, whether seizures are continuing despite rescue medications, or whether they have death or hypotension or cardiac arrhythmias. This trial, as I said earlier, will begin in approximately two years, hopefully, and I hope to be able to report the results in the future. I want to end by acknowledging my colleagues in my lab who contributed to many of the studies I showed you, and also my colleagues in clinical trials who spread all across the world and are listed here. Thank you.
Jaideep, thank you. That was absolutely fantastic, going from the clinic to the basic science and then back to the clinic. There's a question already. So this is, could you clarify the role of KCC2 in status epilepticus? Again, in mature neurons, this channel normally leads to egress of chloride. How is this function altered in status epilepticus?
I misspoke in my talk. KCC2 that's the one that gets internalized during seizures and status epilepticus. A good bit of work coming out of several labs in South Africa and in Boston showing that the internalization of these these transporters leads to chloride loading and a depolarizing GABA effect up to the point that it may be excitatory. So if you knock out the channel, you can even have seizures.
Jaideep, another question that comes to me is that, over and over again, it's been shown that benzodiazepine or GABAergic drugs are probably the best first-line treatment and even probably the best second-line treatment. But you know, they're obviously imperfect because we develop resistance towards them. Would there be an alternative, do you think? Is there something that you could consider that might be better than the benzodiazepines that we're using at the moment?
And as a first line?
As a first line? Yeah, as a first line.
I mean, Eugen makes the point that phenobarbital may be better. Theoretically, you could argue that that a drug that is works on all kinds of GABA-A receptors, not just the synaptic ones, which is what barbiturates do, might be better. But I think clinically, the biggest challenge isn't stopping seizures as much initially, as much as stopping seizures without putting them on a ventilator. Imagine if you were to start with a midazolam drip on everybody would get treated, but everybody would get intubated, right? So the balance in clinical world is how do you stop seizures without compromising respiration, right?
Yeah. And another question that just comes to me, and I think really probably the last question of the session, really. In your trial, you're using ketamine with levetiracetam. Wouldn't it be more sensible to use it with a GABAergic drug, since ketamine will be there preventing the internalization of GABA-A receptors, rather than with levetiracetam?
So they all have to fail benzos, right? So they will all get adequate doses of benzodiazepine. So there'll be a GABAergic drug on board. Then they get either lev alone or lev with ketamine. So they have to have GABAergic drugs on board to start with. Okay.
Excellent. Well, I'm afraid I'm going to have to wrap up the whole session there because we're out of time. There are lots of questions that I think people want to ask, and there are questions that I'd like to ask as well. But I'd like to thank all the speakers for what has been a really excellent session, combining both the most up-to-date neuroscience with the clinical aspects as well, to show really how the two can combine to improve our treatment of this devastating condition. And also I'd like to thank the two Data Blitz speakers for their incredibly clear and very informative talks. So thank you all very much, and thank you for attending the session.